In today's video, we'll be studying joints, and here we have the outline of all we'll be discussing: the meaning of joints, classification and subclassifications, bursy and tendon sheaths, joint stability, and lastly, clinical correlates. Now, taking a look at the first on our outline, which is the meaning of joints. A joint is a point where two or more bones meet, and we're very familiar with this definition of joint. It has not changed. A joint still remains that point where two or more bones meet. Now, joints have a lot of functions, just as the bones of our body have functions. So joints help us to move. Okay, so we have mobility. In addition to mobility, joints help to hold or keep bones together. It's at joints that two or more bones meet, so we can't have the entire skeleton without joints. Now, in the process of keeping our bones together and forming kind of like a junction between bones, joints also provide protection. Okay, for example, the joints between the cranial bones help to provide protection to the brain. As we'd go on to see, there are other protective functions of joints. Now, it's very important for us to take note of these two facts: stability and mobility. Of course, as we go on in this video, we'd see that stability and mobility are two factors that are kind of opposing. So in order for you to maintain high stability, you would have to compromise on mobility, and in order for you to have high mobility, you would have to compromise on stability. So the higher the stability, the lower the mobility. Now, as we go on in our study of this video, we'll get to see that most of the joints that form the axial skeleton are very stable. However, the high stability of the joints of the axial skeleton means low mobility. So for example, cranial bones of the skull have very low mobility. This is why it's so stable, and the stability of the joints between the cranial bones is actually what helps in providing protective functions. When a joint is very stable and there's little or no mobility, it's more protective. However, when a joint is highly mobile, of course for locomotory functions like our limbs, as well as for manipulating functions, working with objects. Now let's take a look at the classification of joints. Joints are classified under two major headings. Okay, so joints could be classified functionally, so we have the functional classification of joints, and joints could be classified structurally. So we have the structural classification of joints. Now, under the functional classification of joints, this tells us whether or not the joint is movable. Okay, so we could have a joint that is totally immovable. So we could have an immovable joint, and we have a fancy term for this, which is synarthrosis. So the immovable joint would be synarthrosis. We could have a joint that is partially movable, and the term for this would be amphithrosis. And of course, we could have a joint that is freely movable. A freely movable joint would have the term diarthrosis. Now, for the structural classification helps us to understand the type of structure that connects the bones. For structural classification, we could have fibrous joints. Of course, for fibrous joints, we would have fibrous connective tissues connecting the two articulating bones. We could have cartilaginous joints, and we could also have synovial joints. Now, of all the three classification of structural joints, the synovial joint is the only joint type with a joint cavity. We'll go on to see this in more details when we take a look at the structure of the synovial joint. Now, we can match the functional joints to the structural joint, and as we would go on to see, fibrous joints are mostly immovable joints, so synarthrosis. Cartilaginous joints are mostly partially movable, so we have amphithrosis. And finally, synovial joints are usually freely movable, so this would be diarthrosis. Now, this is not to say that all cartilaginous joints are amphithrosis or are partially movable. There are exceptions to this classification of, or to the matching of functional to structural. Now let's take a look at some of the fibrous joints that we have. Now there are three sub-classification of fibrous joints. So we have sutures, we have syndesmosis, and lastly we have gomphosis. We have the sutures mainly between the cranial bones of the skull, and for sutures we have a very thin fibrous tissue connecting the interlocking parts of the bones. Okay, so we have, for example, a picture that looks like this. In this picture we can see the wavy interlocking parts of the bone. Now between these wavy interlocking parts we have thin connective tissue that helps to join the bones together, and of course, as we know, the bones of the skull are immovable, so stability is high here. The stability of this joint is high, so of course mobility is compromised. So we have a thin fibrous tissue between these interlocking portions of the bone and they form a suture. Now suture literally means seam. We have surgical sutures, kind of like sewing surgical incisions. So yes, sutures are a type of fibrous joint. Now the next type of fibrous joint is syndesmosis. Now for the syndesmosis, what we have connecting the two or more articulating bones, we have ligament, or we have basically a bar of connective tissue. Because the ligament is much longer than the thin fibrous tissue between the sutures, it's expected that there is higher mobility. Okay, so mobility is somewhat higher for syndesmosis than it is for sutures. We have, for example, in the interosseous membrane between the ulna and the radius, which allows for pronation and supination. Alright, here in this picture we can see the suture line of the skull. We can also see the interosseous membrane between the ulna and the radius, and this would be syndesmosis. And now syndesmos literally means ligament. Because of the length, because the length of this fibrous tissue is much longer than what we have here, it allows for more mobility. Okay, of course, now the last subclassification of fibrous joints is the gomphosis, and we have this type of joint restricted to the tooth. The gomphosis is kind of peg to socket joint that connects the root of the tooth to the upper and lower jaw. Okay, just as we have in this picture. And of course, it's a fibrous joint, and the fibrous tissue that connects the root of the tooth to the upper or lower jaw is the periodontal ligaments. Now, very important for us to take note of is what we have here in the suture joint. So in the suture joint, as I stated earlier, we have this thin fibrous connective tissue that connects the interlocking edges of the cranial bones. Now it's very important for us to take note of the fact that over time, as we age, this fibrous connective tissue becomes ossified. Okay, so we have what we call a closed suture. A closed suture is formed when this fibrous tissue becomes ossified. Now when the suture or when the connective tissue becomes ossified, what we now have is a synostosis. Okay, now let's take a look at the cartilaginous joint. For the fibrous joint, we said what we have is fibrous connective tissue. Now it would be expected that for the cartilaginous joint, what we have between the articulating bone is cartilage. So for the cartilaginous joint, it could be synchondrosis, and then we could have symphysis. Now the synchondrosis, what we have, the type of cartilage we have for synchondrosis is hyaline cartilage. So we have hyaline cartilage between the two or more articulating bones. And then for the symphysis, what we have, the type of cartilage we have is the fibrocartilage. Now in our video on bones osteology, we discussed that we have a thin bar or a thin plate of hyaline cartilage between the epiphysis and the diaphysis of long bone. That plate or that bar of cartilage, we called it the epiphyseal plate. It's very important for us to take note of the fact that that epiphyseal plate is hyaline cartilage that connects the epiphysis and the diaphysis. So the joint between the epiphysis and diaphysis of long bones is synchondrosis. It's a type of cartilaginous joint, specifically the synchondrosis. Okay, and of course, as we stated in our video on bones, we said over time, as this bar of cartilage allows for the accommodation of growth, over time it becomes diminished or kind of like totally ossified into bone, and then it becomes synostosis. Okay, just as we have for the suture joint as well. Of course, as I stated earlier, we have this between the epiphysis and the diaphysis of long bone. Now for the symphysis, of course, we have fibrous cartilage connecting between the articulating bones of the joints, and a good example would be the pubic symphysis as a very good example here. And we also have fibrocartilage between the intervertebral bones. Okay, so the intervertebral disc is made of fibrocartilage, and of course the joint between the vertebra would be symphysis, would be an example of symphysis. All right, so in this picture we can see the thin layer of the epiphyseal plate, so the joint between the epiphysis and the diaphysis, the shaft of the bone, would be a synchondrosis. Here in this picture we can see the intervertebral discs connecting between the two articulating bones. Now let's take a look at the synovial joints. Alright, now most of the joints in our limbs, okay, so for the upper limb and the lower limb, are synovial joints. There are about 6 distinguishing features of the synovial joints which we would consider in this video. Of course, we said that of the 3 structural classification of joints, only the synovial joints have a joint cavity. Okay, now in this picture we can see the structure of the synovial joints. Now in the synovial joint we have the articular cartilage. Now the articular cartilage is a hyaline cartilage, and it's the cartilage that covers the articulating surface of the bone. In this picture we can see highlighted in red would be the articular cartilage, and it's made of hyaline cartilage. It's what covers the epiphysis at the articulating surface. Now of course, apart from the articular cartilage, which is one of the features of the synovial joint, we also have the joint cavity. It's called the joint cavity or the articular cavity. Now the joint cavity or the articular cavity is a potential space. Okay, so unlike as it's illustrated in this picture, it's not always this large. Okay, so however, when there's an accumulation of fluid, of course it can become as large as it is here. Within the joint cavity or the articular cavity, we have the synovial fluid. Now as we would go on to see, the synovial fluid acts as a lubricant. Okay, so it acts as a lubricant between these two bones. It has an egg white consistency. Okay, so viscous egg white consistency. Now also, this is partly due to the hyaluronic acid that is produced by the synovial membrane. And of course, we'd go on to see that a huge part of the synovial fluid is actually formed from filtered fluid from blood that supplies the synovial membrane. And of course, we'd have the synovial membrane as another feature of synovial joints. Now the synovial membrane is made of loose connective tissue, and it's vascularized and innervated. Okay, and as I stated earlier, a huge part of the synovial fluid is actually formed from filtered fluid from the blood that supplies the synovial membrane. Now the synovial membrane forms part of the articular capsule alongside the fibrous layer. So we'd have a fibrous layer. So far we have seen 1, 2, 3, 4, 5 features of the synovial joint. The last feature of the synovial joint would be the supporting or reinforcing ligament. Now of course, probably familiar with the term ligament. The ligament is a fibrous tissue that holds articulating bones of a joint together. Now taking a look at the term synovial, ovial. Okay, ovial relates to the ovum, and the ovum means egg. Syn means joint. Okay, so we have synovial meaning joint egg. Of course, so it makes sense that the consistency, okay, kind of like the thickness of the synovial fluid is of egg white. Also, it's important for us to take note of the fact that we have some phagocystic cells within the synovial fluid, and these phagocystic cells help to engulf certain microbes that may invade the synovial fluid, so to say, an immune regulation for the joint. When we consider the reinforcing ligaments, it's important for us to take note of the fact that these reinforcing ligaments could be capsular, okay, it could be intracapsular, so within the capsule of the joint, and it could be extracapsular, outside the capsule of the joint. Now, when the reinforcing ligament exists as a capsular ligament, it usually forms part of the fibrous layer of the articular capsule. Okay, so it's just kind of like a thickened part of the fibrous layer of the articular capsule. Of course, here in this picture we can see the articular capsule. The articular capsule is made of both the synovial membrane and the fibrous layer. So when we have a capsular ligament, the capsular ligament would simply be a kind of like a thickened portion of the articular fibrous layer. So far we have considered the meaning of joints. We said that a joint is a point where two or more bones meet. We have classified joints structurally and functionally. We have also seen some of the sub-classification of joints. Now, very quickly, let's just take a look at some of the sub-classification of synovial joints. Because synovial joints are mainly freely movable joints, they are classified based on the type of movement that they accommodate. Okay, so we have plane joints. Plane joints are a type of synovial joint where we have flat articulating surface. So for plane joints, we have flat articular surfaces. And an example would be the acromioclavicular joint of the upper limb, joint between the acromion of the scapula and the clavicle. Okay, so the acromial end of the clavicle. This type of joint allows for gliding movement, and gliding movement is a type of non-axial movement. It's a non-axial movement because it doesn't exactly take place in a particular axis. So as we would go on to see, we could have a non-axial movement, we could have a biaxial movement, as well as a multi-axial movement. So a multi-axial movement takes place in multiple axes of the body. So this is the plane joint. The next type of joint would be considering is the hinge joint. Now for the hinge joint, what we have is a uniaxial movement. It allows for flexion as well as extension. Okay, now we discussed all of this anatomical movement in our video on anatomical movement. Please kindly check out the video on anatomical movement to gain some more knowledge on anatomical movements. For the hinge joint, what we have for the hinge joint is a kind of stopper. Okay, so we have a kind of stopper for hinge joint. A good example of the hinge joint would be the elbow joint and as well as the knee joint. Now, how exactly do hinge joints have stoppers? Let's take a look at just the general structure of what the elbow joint looks like. For the elbow joint, we have the humerus. This would just be a line representation of what the elbow joint looks like. So we have the humerus, we have the olecranon fossa of the humerus, and then we have the olecranon process of the ulna. The olecranon process of the ulna articulates with the olecranon fossa of the humerus in a way that looks something like this. The olecranon process acts as a stopper in this way. So when we flex our elbow, it allows for flexing. So we can flex our elbow in this direction, something like this. However, when we extend our elbow in this direction, take note of the depression and the process. Because of the depression and the process of the olecranon, both the olecranon fossa as well as the olecranon process, it would prevent a hyperextension. Okay, so the ulna and the radius, of course, would not be able to move further. So once they get to a position that looks something like this, they would be unable to go further to, say, a position like this. Okay, so the olecranon fossa and process acts as stopper for the elbow joint. And of course, for the knee joint, we have the patella acting as a stopper. Okay, so this would be the femur, and then of course we'd have the tibia and the fibula and the lower leg. The patella on this side prevents hyperextension as well, just as the olecranon of the upper limb prevents hyperextension. This would be of course the anterior portion. That's why we can't move the lower leg to say a position like this because of the stopper of the patella. However, there's no stopper on the posterior side, and so that's why we can bend our knee in this direction. Okay, so flexion and extension. I hope this illustration helps us to understand. Okay, so we have seen the plane joints where we said we have flat articular surfaces. It allows for non-axial movement, which of course we gave the example of gliding movement of the acromioclavicular joint. Then we went on to see the hinge joint where we have kind of like a stopper preventing hyperextensions. It only allows for flexion and extension basically. The next type of synovial joint we'd be considering is the condyloid joint. For the condyloid joint, it's also called the ellipsoidal joint or the ellipsoid joint. In this joint, what we have is that we have an oval depression and an oval surface, kind of like a fossa and a process. We could have something like this, and then this would be the depression, okay, and of course this would be the surface. So this is how a condyloid joint looks like, or how it acts like. And of course, we would have this joint between the metacarpal and the phalanges, for example. Metacarpophalangeal joints would be an example. And this allows for flexion, and it allows for extension. It also allows for adduction and abduction. The next synovial joint we'll be considering is the pivot or pivot joint. Now this has kind of like an axle and a sleeve. Okay, so of course we'd expect that it allows for rotations. We'd have a rounded bone or ligament, and then we'd have a rod shaped bone that can kind of like rotate within this rounded bone or ligament. A good example would be the proximal radio-ulnar joint. Now for the proximal radio-ulnar joint, we have the ulna, and of course for the ulna we have the radial notch of the ulna, and then we have the head of the radius fitting into the radial notch in this way, and surrounding the head is what we call the annular ligament. Okay, so of course we can see in this case that this rounded band, which acts as the sleeve, is a ligament, not a rounded bone. And then of course we have the axle, which is the radius. Another very good example of the pivot joint or the pivot joint is the allantoaxial joint. Now the allantoaxial joint is the joint between the axis and the atlas. These are the first two cervical vertebrae. For the allantoaxial joint, we have the axis with a process that looks something like this. So this would of course be the axial, and then we have the atlas with a foramen where the process of the axis can go through. Okay, and this is what allows for the sideways movement, so we can rotate our head left and right. Okay, so this is an example of a pivot joint. Now lastly, let's take a look at the ball and socket joint, which is the last example for the synovial joint. We're probably very familiar with the ball and socket joint. Okay, so basically we have a ball that fits into a socket, something like this. Now a good example of this would be the glenohumeral joint, as well as the hip joint between the femur and the hip bone. As we'd go on to see, the socket provided by the hip bone is big enough for the ball of the femur. However, for the glenohumeral joint, the socket provided by the glenoid cavity is much smaller than the ball of the head of the humerus. Okay, the head of the humerus is about 3 times larger than the socket. This decreases the stability of the joint. When we discuss joint stability, we'll get to see how the shape of the articular surface can affect the stability of the joint. Also, of course, we have lastly the saddle joint. For the articulating surface of the saddle joint, they have a concave and a convex articular surface. A good example would be the carpometacarpal joint at the base of the thumb. So we have kind of like a concave and a convex structure. Alright, so we've taken a look at the meaning of joints, the subclassification and classification. Now let's take a look at the bossy and the tendon sheath. Alright, earlier we considered the synovial joints, and we said within the synovial joints we have about 6 distinguishing features, part of which we saw the synovial fluid and as well as the presence of a joint cavity. Now it's good for us to take note of 2 very important structures that help to prevent friction. This would be the bossy and the tendon sheath. The bossy, it's a flat fibrous sac and it's lined with synovial membrane that produces synovial fluid. You usually have the bossy at a place where you would have either a ligament or a muscle is likely to rub against a bone. Okay, so a very good example would be in the upper limb where we have the acromion of the scapula. Between the acromion of the scapula and the head of the humerus, the proximal part of the humerus, we have the subacromial space. Within this subacromial space, there's a likelihood of a ligament rubbing against the bone. In this case, we have the subacromial bossy. Kind of like a specialized bossy, so to say, would be the tendon sheath. So the tendon sheath is kind of like an elongated bossy, and it usually surrounds a tendon where the tendon is likely to experience friction. A good example would be the tendon sheath that surrounds the tendon, the long head of the bicep. Now the tendon of the long head of the bicep passes through the intertubercular sulcus of the humerus. We have the humerus, we have the greater tubercle of the humerus and the lesser tubercle of the humerus, and between these tubercle we have the sulcus. Okay, now the tendon of the long head of the bicep passes through this intertubercular sulcus or bicipital groove. Alright, so here we have a picture where we have the subacromial bossy. Here highlighted in red is the subacromial bossy occupying the subacromial space. So this would be the subacromial space. And then of course here this is the long head. This is the tendon of the long head of the bicep being surrounded by the tendon sheath. This is the tendon sheath highlighted here. Okay, and as we can see, it's kind of like a specialized bossy. It's like an elongated bossy that surrounds tendon. So these are some structures that are put in place to prevent friction and wearing of ligament or bones, the articular surfaces that make up the joints. Alright, so we have considered the bossy and the tendon sheath. Now let's take a brief look at joint stability. There are a number of factors that affect how stable a joint is or how stable a joint would be, and as I stated earlier, stability and mobility are 2 factors that are kind of opposing. Okay, so the more stable, the less mobile, the more mobile, the less stable. For this video, we'll be considering 2 factors that affect the stability of the joint or of a joint, and this would be the shape of the articulating surfaces. The next would be considering is ligament, and lastly would be considering muscle tone. First, taking a look at the shape of the articular surface. When we were discussing the ball and socket joint, especially the glenohumeral joint, we mentioned that the glenoid fossa or the glenoid cavity of the scapula is much smaller than the head of the humerus, so it doesn't exactly provide that ball and socket articulation needed. So this joint is kind of unstable. However, as we would go on to say, there are other features put in place to stabilize the joint, part of which we have here. We have the rotator cuff muscles put in place, we have some supporting ligaments, and we also have a fibrocartilage. We have the labrium of the glenohumeral joints that kind of increases the surface area of the glenoid cavity. Okay, so the shape of the articular surfaces can greatly influence the stability of the joint. A good example of when the shape of the articular surfaces enhance the stability would of course be in the hip joint. Unlike the glenohumeral joints or the shoulder joints, where the head of the humerus is much bigger than the glenoid cavity, for the hip joints we have that the femur perfectly, almost entirely perfectly fits into the ball provided by the hip bone. So this is a good example of where the shape of the articular surface plays a good role in joint stability. So we would find that in terms of stability, the ball and socket joint of the hip joint is far more stable. That's of course strictly considering shape of articular surface. With respect to shape of articular surface, the hip joint is more stable than the shoulder joint. Next, of course, would be ligaments. Of course, as we already know, the ligaments are this fibrous tissue that help to hold bones together in a joint. Okay, so we'd have, say, a bone like this, and then would have another bone, and ligaments would be this structure that kind of wraps around the bone to hold them together in place, preventing them from slipping off, so to say. It's quite evident that ligaments play a role in stability. However, it's good for us to take note of the fact that the role that ligaments play in joint stability is very much limited. And when there is a lot of stress on the ligament, okay, so when the ligament is the prime stabilizer of the joint is generally relatively unstable. And this is because of the general fibrous nature of the ligament. The ligament, it's important for us to take note of this, that the ligament can only stretch to about 6% of its original length. Once the ligament has stretched beyond 6% of its original length, it snaps and tears off, and that's why we have situations of sprain. The next factor would be considering that affects joint stability is muscle tone, and a very good example of this would be for the rotator cuff muscles. Now, in the upper limb, we have these rotator cuff muscles, and the rotator cuff muscles that help in stabilizing the glenohumeral joint, which is simply the joint between the glenoid cavity of the scapula and the head of the humerus. Okay, so we have these rotator cuff muscles that help to stabilize the joint, and the rotator cuff muscles are the supraspinatus, the infraspinatus, the subscapularis, and lastly we have the teres minor. These are the 4 rotator cuff muscles that help to stabilize the glenohumeral joint. Now, how exactly does muscle tone play a role in joint stability? Now, it's good for us to understand what muscle tone means and what muscle tone is. Now, generally when we talk about muscles, we have certain terms that are associated with muscles like hypertrophy and atrophy. We also have terms like contractile or contraction. We have terms like relaxation, excitability, and so on. Okay, now generally when we think of movement involve contraction and relaxation, and would usually say, for example, that the biceps brachii of the arm contracts when we flex and it relaxes when we extend. Okay, so the biceps brachii, for example, would be an example of a muscle that is contracted when we flex our forearm and it's relaxed when we extend our forearm. However, it's good for us to take note of the fact that no muscle is in a total state of relaxation at any point in time. Even when a muscle is inactive, it's not completely relaxed. Okay, now this low level of contractile activity of a relaxed muscle is what we call muscle tone. Now, muscle tone is very important because when a muscle loses its tone, it actually experiences retardation in responding to stimulus. Okay, so the muscle tone, which is associated with this low level of contractile activity, actually is what keeps the muscle healthy and keeps it ready to respond to stimulus. Now, as I stated earlier, this stabilizing muscle of the glenohumeral joint helps to stabilize the joint, of course, and the muscle tone, the maintenance of the muscle tone of these 4 muscles would help to keep the joint stabilized. Take, for instance, these 4 muscles lost their muscle tone. Of course, it would affect the stability of the joint in general. Now, going by our outline, we're almost done with our study. Now, let's take a look at some clinical correlates of all that we have learned so far. Now, for the clinical correlates, we'd be considering the clinical correlates of joints under two headings. So we'd be considering common joint injuries as well as some inflammatory and degenerative conditions of joints. Under the joint injuries, we'd be considering cartilage tear. Cartilage tear, simply put, as the name implies, is simply when there is a tear in the cartilage. Okay, this cartilage, of course, could be the articular cartilage, and a common site of cartilage tear would be in the knee joint. Okay, so in the knee joint, we have the lateral meniscus as well as the medial meniscus of the knee joint. Now, there are certain activities and certain movements that can lead to the tear of this meniscus, and a fragmented cartilage could actually hinder movement to an extent. And when we were discussing on cartilage, we did mention that unlike bones, cartilages are avascular. Avascular simply means that they do not have a blood supply, and this of course implies that a tear to the cartilage or a damage to the cartilage would mean that they would be unable to heal. Since there is no blood supply, they would be unable to regenerate and heal. So this cartilage would have to be removed, and the cartilage could be removed by arthroscopic surgery. Now, literally, arthroscopic simply means looking at the joint. Scopic has to do with looking, and arthro, whenever we hear the word arthrology, it has to do with the joint. So in an arthroscopic surgery, the surgeon makes use of an arthroscope. Okay, now the arthroscope is this device. It has a thin lens as well as a light source, a fiber optic light source. Alright, so here in this picture, we can see the arthroscope. Okay, so the arthroscope has a camera and a fiber optic light source, and of course it's minimally invasive. Okay, it's a minimally invasive technique of surgery. Basically, there would be a screen where the surgeon would be able to look into the joints, literally, as the name of the surgery implies, and be able to remove the fragmented cartilages that have been torn. And if the individual that has experienced this cartilage tear, in the case where it's a meniscal cartilage tear, then the person could go for a meniscal transplant or a meniscus transplant. Another joint injury would be considering for this video is sprain. A sprain is basically where there is a partial or total tear of the ligament. Okay, so this of course occurs where the ligament is partially or totally torn, and as I stated earlier, the ligament can only stretch to 6% of its length. Now, why is this so important? Generally, when a ligament is torn partially, it will generally heal on its own. However, a total tear to the ligament, there would be only three options. An option would be to sew the ligament up. However, this is very difficult because the ligament is a fibrous tissue, so you just have these lines of fiber together in the ligament. Now, the text I studied with illustrates sewing of a ligament in a very interesting way, and it describes sewing of ligament as an attempt to sew together two hairbrushes. So imagine two hairbrushes with how they are made up of these bristles, and imagine trying to sew these two hairbrushes together. Okay, that's like trying to sew ligaments together. Another option would be grafting. So for grafting, this would of course make use of probably a tendon from a different part of the body, and then it would graft it into the ligament that is torn. And another option would be immobilization. Now, immobilization literally means that probably the part of the body would be held together in order to prevent movement, and over time possibly the ligament could come back together and heal. Another common injury is dislocation. Now, dislocation occurs when a bone is forced out of alignment. Okay, so you have an original position of the bone, an original location of the bone, and it's dislocated. It's taken out of its location. It's forced out of alignment. There's a fancy term for dislocation, and it's called luxation. And just as we discussed fracture, okay, so when we discussed fracture, we said we could have partial fracture, we could have displaced, displaced, we could have compound or simple, and so on. And we said some fractures can actually be reduced. Okay, so we made use of the term reduction, and we said reduction simply is mainly non-invasive. So the doctor or the surgeon or the healthcare provider simply uses the hand to put the bones back in place. So the bones are coaxed back in place, just shifted back in place for fracture, and then they would naturally heal up. Okay, and of course, because the bone is vascularized, you'd have the formation of the hematoma, then the callus, and then the bone eventually heals up. Okay, same thing applies for a dislocation. A dislocation can of course be repaired by simple reduction. Okay, so the bone is just realigned without surgery. And another important term for us to take note of is subluxation. Sub means below, partial. Subluxation is a partial dislocation. The bone is not totally out of its position. So these are the common joint injuries we'll be considering in this video. Let's take a look at some inflammatory conditions of the joint. For this video, we'll be considering just a few inflammatory conditions of the joint. And the first inflammatory condition, or the first two inflammatory conditions we'll be considering, are bursitis and tendinitis. Bursitis has to do with inflammation of the bursae, and tendinitis has to do with the inflammation of the tendon sheath. For bursitis, we'd be taking a look at two examples of bursitis. The first would be the prepatellar bursitis. This involves the inflammation of the prepatellar bursae, and then we have the olecranon bursitis. This has to do with the inflammation of the olecranon bursae. The prepatellar bursitis is sometimes called the housemaid knee. It's also sometimes called water on the knee. Okay, so as I said earlier, it's an inflammation to the prepatellar bursae. For the olecranon bursitis, it's an inflammation of the olecranon bursae, and it's sometimes called the student's elbow. Alright, here in this picture, we can see an inflammation on the knee in this picture, and this is a prepatellar bursitis. Basically, we have the structure of the knee looking like this. Here, of course, we can see the prepatellar bursae. Okay, so when there's an inflammation to this prepatellar bursae, what we would have would be the prepatellar bursitis that looks something like this. Of course, as I stated earlier, the prepatellar bursitis is sometimes called the housemaid knee, and this is because it's assumed that the housemaid would maintain this position and so could actually be affected by prepatellar bursitis. But generally, prepatellar bursitis could result from just falling on one's knee. And of course, we have the student's elbow. We can see an inflammation of the olecranon bursae as illustrated in this picture. Okay, so the picture here shows a normal structure of the elbow joint, and we can see here the olecranon bursae. Okay, so an inflammation to the olecranon bursae would lead to the student's elbow or olecranon bursitis. And of course, this is another term, student's elbow. It's assumed that the student or students would generally lean for a prolonged time on their elbow. Okay, so olecranon bursitis or the student's elbow is caused mainly by prolonged leaning on one's elbow. It could cause for an inflammation of the olecranon bursae. Now, of course, because these are inflammatory conditions, anti-inflammatory drugs could be administered, and when the inflammation is caused by an accumulation of fluid, then a treatment could be needle aspiration. Now, the needle aspiration simply involves using a needle and a syringe to remove some of the accumulated fluid within the bursae. So it would look something like this. Okay, so here in this picture, we can see this is an ongoing needle aspiration. So we can see the syringe being used to extract some of the accumulated fluid from the prepatellar bursae. Now, another key inflammatory condition of the joints would be arthritis. And arthritis is not a particular disease. Arthritis actually refers to over 100 different inflammatory conditions. And for this video, we'll be considering just about three types of arthritis. Okay, the first would be considering is osteoarthritis. Osteoarthritis is more common in women than in men. Okay, and it's usually associated with eroded articular cartilage. Now, when we were studying the structure of the synovial joints, we saw that we had the articular cartilage made of hyaline cartilage covering the articular surface of the bone. So we had the bone and then the articular cartilage. In osteoarthritis, what we have is that this articular cartilage is eroded. Okay, and of course it would lead to wearing and tearing of the joints. Another type of arthritis would be considering is rheumatoid arthritis. Now, rheumatoid arthritis is an autoimmune disease. It's an autoimmune disease, meaning that generally, of course, in our body we have the immune system, and immune system generally fight against foreign bodies. However, in autoimmune disease, what we have is that we have the immune system fighting against its own tissues. Okay, so fighting against the body's tissue, okay, not foreign bodies now, and especially the tissues of the joint. Okay, that's in rheumatoid arthritis. Now, it's good for us to take note of the fact that there are certain nutritional supplements that are administered for the forms of arthritis, especially the osteoarthritis, and this would include things like glycosaminoglycans, glycosamine, and chondroitin sulfate. These are some nutritional supplements that are administered to people suffering from conditions of osteoarthritis and other related forms of arthritis. The last form of arthritis would be considering for this video is the gouty arthritis. Now, unlike osteoarthritis, where we said it's more common among women than men, gouty arthritis is actually more common in men than in women, okay, and it's associated with uric acid. Uric acid is produced from the metabolism of nucleic acid. In an event where we have an accumulation of uric acid, either as a result of excessive production of uric acid or lack of excretion of uric acid, so generally when uric acid is produced, is excreted by the kidney. However, in a case where we have it such that there's an overproduction of uric acid, or the uric acid is not being removed from the body system, it could actually accumulate within joints. Okay, so it could form what we call urate crystals, and the body would respond to this urate crystal formation by anti-inflammatory reactions, and this anti-inflammatory reaction on the uric crystal would actually cause pain and stiffness of the joints. Okay, and it's believed to an extent that the reason why gouty arthritis is more common in men than in women is because, of course, women have a higher amount of estrogen. Okay, estrogen is mostly considered a female sex hormone. Okay, and estrogen plays a key role in uric acid excretion. Okay, so of course, because men have lower estrogen, it's kind of expected that their uric acid excretion would be low. Now, of course, gouty arthritis can be avoided by abstinence from alcohol. So alcohol consumption is a risk factor for gouty arthritis. Also, certain diets or certain foods that contain purine. Okay, so we probably familiar with purine, where we have adenine. From DNA we have adenine and guanine. Now, certain foods contain purine. There are certain fishes that contain purine. It's good for us to avoid such foods because, of course, metabolism of this food would lead to the production of uric acid, and over time it could actually lead to gouty arthritis, although it's more common in men than in women. Okay, now it's important for us to take note of the fact that although arthritis refers to over 100 different inflammatory diseases of the joint, they usually present similar symptoms to varying degrees, and these symptoms would include pain at the joint, stiffness of the joint, as well as swelling of the joints. Now, this is not to say that anytime we have a pain or we have stiffness or we have swelling, then it's an indication of arthritis. Or, of course, this could be caused by other factors. Now, it's also good for us to take note of the fact that we could have chronic and acute arthritis. Acute arthritis is mainly caused by bacterial invasion. Okay, so certain bacterial invasion at the joints. Acute arthritis is mainly usually caused by bacterial invasion of the joint. It's acute, okay, so it's an acute inflammatory condition and it could be treated with antibiotics. Okay, it's acute, so it's sudden, of course, but it may be severe. However, a chronic arthritis would be one that has been developing over time, and of course examples would be osteoarthritis, rheumatoid arthritis, and of course gouty arthritis. So it's just good for us to take note of the difference between acute and chronic arthritis. Acute arthritis, as I said earlier, can be treated with antibiotics, and also very important, the symptoms that arthritis would usually display: stiffness, pain, and swelling. Of course, it could be in varying degrees, so a particular type of arthritis could be associated with more stiffness than swelling, and a different type could be associated with more pain than stiffness and swelling. So it's important for us to take note of that. Alright, so far we have considered the meaning of joints, the classification of joints, subclassification, bossy and tendon sheet, joint stability, and clinical correlates. Now, of course, there are other clinically related conditions of joints, and just as a brief overview of all we have discussed so far, we saw that a joint is a point where two or more bones meet. We classify joints structurally and functionally. For the functional classification, we had synarthrosis, amphitrosis, and diatrosis. For the structural classification, we had cartilaginous joints, fibrous joints, and synovial joints. We went on to see the bossy and the tendon sheets. So for joint stability, we said we have three major factors that influence or affect joint stability. We considered muscle tone, the presence of ligaments, as well as the shape of the articular surfaces. Also for the clinical correlates, we did see that we have some common joint injuries like sprain, cartilage tear, and dislocation. And then for the inflammatory condition, we took a look at bursitis, tendinitis, and about three different types of arthritis: osteoarthritis, rheumatoid arthritis, as well as gouty arthritis. If you liked this video, please give it a thumbs up and don't forget to subscribe. Thank you for watching till the end. Bye.